Good evening, everyone. My name is Ben, and I'm a health educator here from the Hospital Research Foundation Group Arthritis, and I thank everyone for joining us for our webinar tonight. First and foremost, I'd like to do an acknowledgement of country, and that I acknowledge that both myself and our presenters tonight present from Ghana land, and we pay our respects to elders past, present, and emerging. I'd also like to acknowledge the funder of tonight's webinar, which is the Country SA PHN, and we thank them for this. Now, we've got a very exciting webinar tonight. We've got Professor Maureen Rischmueller to present on both lupus and Sjögren's disease. And then we've taken some questions in during the sign-ups, and then we'll get to answering those at the end. So if anyone isn't aware of Professor Maureen Rischmueller, she's a consultant rheumatologist at the Queen Elizabeth Hospital, the Royal Darwin and Alice Springs Hospitals, and a clinical professor at the University of Adelaide. Her research interests focus on inflammatory rheumatic diseases, including Sjögren's disease, systemic lupus, and then scleroderma and vasculitis. She leads a translational research program and clinical trials unit at the Queen Elizabeth Hospital, investigating pathogenic mechanisms, novel antibodies, genetic risk factors, clinical manifestations, and novel treatments. She's also chair and custodian of the South Australian Sjögren's Repository and Biobank, and co-chair of the International OMERAC Sjögren's Special Interest Group. She's a member of many different foundations around Sjögren's and lupus, including the Sjögren's Genetic Network, European Sjögren's Task Force and Big Data Consortium, the Australian Lupus Registry and Repository Steering Committee, Indigenous Australian Rheumatic Disease Consortium, and the Australian Scleroderma Interest Group Scientific Committee. In her spare time, it's dedicated to establishing the first Australian Sjögren's disease registry and repository. We're very lucky to have Maureen on tonight, and I'll hand over to her.
Thanks very much, Ben, and thank you for inviting me to speak tonight. I'm really keen on this Q&A because I think they're both such important disorders that aren't really well known, I don't think, in the community. So I'm doing them together because there's a lot of overlap between Sjögren's, which is now called Sjögren's disease rather than syndrome, and it's systemic lupus erythematosus, which we either shorten to SLE or lupus. So both of them are autoimmune conditions, meaning the body's natural defense system, being the immune system, attacks itself. It may affect multiple organs, but it can be very mild and can be very severe. So everybody's different. It tends to be lifelong, or both of them. So chronic, they may relapse, they may remit. So you may have years without any problems, or some people have problems all the time from them. So very variable. I'm sorry if you can hear my dog howling in the background. She should be quiet soon. So there are many shared features between Sjögren's and lupus, being the autoantibodies. So anti-nuclear antibodies are the main ones. Then there's another number of autoantibodies, but particularly the anti-Ro or SSA can be seen often in both of those disorders. And the way they can affect the blood and the risk factors for getting them in the first place, the genetics that we know about so far are shared between the two disorders, with some different and many the same. Drugs are there are certain drugs that can bring on lupus, but none have really been defined for Sjögren's, so that's a difference. Sjögren's is very common. It's about 1 in 100 people, so it's similar to rheumatoid arthritis, and it's very female directed, so about 20 females to 1 male are affected, and the age of the peak onset is between 40 and 60 years of age. So the lupus is less common, so about 1 in 1,000 in Asia, perhaps 1 in 10,000 in Caucasian Australians, 1 in 500 in African Americans, so it varies around the world. But again, it's 10 women to 1 man, but a younger age. So the peak incidence is between 15 and 45 years old. So very overlapping disorders, but different age groups and different prevalence. Both can really impact people's well-being though, particularly with fatigue, pain, and in the case of Sjögren's, dryness. We'll talk about that later. And there are implications for both of these diseases on pregnancy for mother and baby, and we'll talk a bit about that too. So this is a cartoon. The middle bit here is the immune system. This shows the nuts and bolts of the immune system. So the cells, the T cells are the bosses. The B cells make antibodies, which are big Y-shaped proteins that clutch on to viruses and bacteria and tag them to be destroyed by the immune system. The immune system uses cytokines, which are chemicals in the blood and tissues to kill organisms and to speak to each other to bring more immune cells in. And then in really bad infections, the immune system's developed these immune complexes, lots of these Y-shaped antibodies holding hands to try and net these organisms like chronic TB. So that's the normal immune system that we all have. In Sjögren's and lupus, there are variations of risk. We're looking at the top line now. So the genes, just the random genes that we inherit, some of them are more pro-inflammatory and can make it more likely that we'll get these disorders. The environment, from food to weather to smoking, many effects from the environment. And again, we'll touch on them later. The way the immune system's regulated, so there's a whole heap that goes into that, and some of it's our development and our childhood, the way our immune system adapts along the way. Hormones, so we know that women are more affected than men. And the epigenetics, that's a new area of research which controls which genes that we've inherited are turned on or turned off at any individual time. So really a random cluster of variations of all these factors can turn the immune system to start recognizing self and to start attacking self. And this just shows some of the organs that can be attacked in both of these disorders. So I don't want you to memorize this, but it's just to show that the diagnosis of lupus, even for doctors, is quite complex. In lupus, we think the immune complexes, these big nets of antibodies, play a big role by being turned on in the immune system and depositing in the bloodstream, in the blood vessels, in the kidneys, in the skin, and turning on the immune system to attack those areas. There are many classification criteria for Sjögren's that really have been developed for research, for entry into clinical trials and that sort of thing, to standardise people that are entering the research. And this is the latest one, 2019, and we sort of use it a bit to make the diagnosis as well. And you'll see right at the top, pretty well everyone needs to have an anti-nuclear antibody or ANA. And then there's a cluster of clinical features on the left, and then some more antibodies that I mentioned earlier on the right, and also these complements that are a part of the activity of the immune system in lupus. So, you know, they add up all of these numbers to see whether you've got a definite case of lupus or a probable or a possible. But in real life, in the clinical situation, we can make a clinical diagnosis of lupus based on, you know, antibodies and clinical features, and it might be early. There might be only one typical clinical feature to date. But, you know, just so that you can see how complex it is for even doctors to understand what they're looking for to make a diagnosis. In Sjögren's syndrome, we really think these boss cells, the T cells, driving the B cells are the main players. So not the immune complexes so much, but the cells getting into the organs and the glands. So particularly the salivary glands here, the main ones, and there's a lot of little ones lining the mouth, and the tear glands up above the eyes that aren't shown here, get invaded. You can see on the right, all of these little purple guys are these cells, B and T cells, invading a gland and stopping it from working properly. So the people mainly, you know, characteristically complain of a dry eye. And on the left, you can see that cloudy bit on the eye is an ulcer. So they can get ulcers and infections and even lose vision. But typically there's a dry, very irritated eye, feeling like something's in it. And the eyes get tired reading. The dry mouth can lead to a lot of dental problems over time. That's a major damage from having Sjögren's or lupus, which can have Sjögren's on top of it. And people often have these very sore, swollen salivary glands as well. And as I mentioned before, Sjögren's can have all these other organs being affected as well. So the diagnosis of Sjögren's is even harder. So it's a combination of how much saliva you produce, how many tears you produce, what the surface of your eye looks like, if there are any little areas where cells are missing from the dryness, a blood test for the autoantibodies. I mentioned the anti-Ro, which is one of the subsets of anti-nuclear antibodies. And then the biopsy, the salivary gland biopsy. Not all patients have to have all of those tests, but we really want to show that there's dryness, and we want to show that there is an autoimmunity going on to cause the dryness, because actually there are hundreds of causes of dry eyes and mouth, including menopause, many drugs, diabetes, and so forth. So for Sjögren's, we need to show autoimmunity either by the biopsy or that Ro antibody in the blood. Okay, so the optimal patient journey from my perspective, and patients may well have a different perspective, I'm sure they do, and that's what I want to learn from you, is a timely, accurate diagnosis. You need a healthcare team, so the GP and the rheumatologist are integral. And then depending on your symptoms of your Sjögren's or lupus, an ophthalmologist, dentist, dermatologist, kidney or lung physician, neurologist, pharmacist is important, particularly as there are a lot of over-the-counter medications that you're using. A physiotherapy specialist or exercise physiologist can do great things. Dietitian and psychologist often offer very good support and help problem solving as well. The next step, I think, is effective management of symptoms, improvement of well-being, and then the things the doctors, the rheumatologists focus on particularly are the prevention of flares, because this leads to progression of disease, and then progression of disease can cause irreversible organ damage. So we want to prevent flares, prevent progression, prevent damage, and that's where we come in with the drugs, with the immune suppressants. Okay, so to do all of this, again, from the doctor's perspective, we need to see you regularly for checkups, and we monitor your symptoms and well-being. We monitor the disease activity, so that's blood tests as well as examination and other tests, and that can fluctuate over time. You know, what we measure at one time might be completely different than a year later. We want to monitor any organ damage, and we want to monitor at each visit the effect or side effects of treatments and make changes at every visit if necessary. But when necessary, we do need to change treatment. That's why we need to see you regularly. Special considerations we won't have time to go into deeply are people with something called antiphospholipid syndrome. This is caused by antibodies called antiphospholipid antibodies. They can occur on their own, but most often they occur in people with lupus, sometimes with Sjögren's, sometimes with scleroderma. These antibodies can cause blood clots in the veins or the arteries, and they can also cause recurrent miscarriages. And if you've had any of these with this antibody, you need lifelong blood thinners. It's really important. Pregnancy is important, particularly in lupus, because if the lupus is controlled very well at the time of conception, it bodes really well for the outcome for mother and baby. If the lupus is very active, these pregnancies need to be monitored very closely, and there may be some drugs that have to be stopped and others that have to be started to ensure a really safe journey through the pregnancy. In Sjögren's, there's an importance as well, because people with Ro SSA antibodies, they can go through the placenta and affect the baby. So we do like to add hydroxychloroquine if the patient's not already taking them. People who do have a baby affected by this, usually it's very mild. Sometimes it's more serious. But many of them have a baby with what we call neonatal lupus, and they haven't even had a diagnosis yet of Sjögren's or lupus. So that's difficult. Usually it ends up being Sjögren's, and because Sjögren starts later, they're diagnosed 10, 20 years after the pregnancy. Okay, so the management. I know that a lot of the Q&A will be about this. So of the dryness, because as I said, people with lupus can get dryness as well. We used to call it secondary Sjögren's, but now we call it lupus and Sjögren's. A multidisciplinary approach is really important, and I advise everyone to see it once at one time, to see an ophthalmologist, so a doctor specialising in the eye, because you can see things, not just a lack of tear production, but there might be inflammation of the white area of your eye, this like scleromalacia or scleritis, and even at the back of the eye, there might be inflammation. So a whole checkup of your eyes. Also, a lot of you may know there can be associated inflammation of the eyelid called blepharitis, and that can cause a drier eye than you've got already. So an eye checkup's important, and there are many really good optometrists that can do this too, but I like you to see the doctor once at least, and then ongoing with the optometrist. So with the mouth side of thing, improve oral hygiene. Regular dental care is really important. Optimally 3 months, but really 6 months is the usual. And topical fluoride's really important to prevent dental caries, which is a big risk of having a dry mouth of any cause. So reducing or avoiding drugs that cause a dry mouth is important. Mechanical saliva stimulation can really work. So having a sugar-free, so you don't exacerbate caries, chewing gum or a lozenge in your mouth, it can be there all the time or after meals, will stimulate some natural saliva. That's very protective of your teeth and your gums. If that's not good enough, you can stimulate saliva production by chemicals, by a drug called pilocarpine. This can have side effects, but it can be very, very useful to slow down tooth decay. With the eye side of things, artificial tears as well as artificial saliva for the mouth can be very useful. They're over the counter at the chemist, and it's worth trying different ones over time because some are good for some people, others prefer others. So there's a difference in thickness or taste or in the eyes, blurriness or not blurriness. So try different brands. Wind protection is important, so wraparound glasses can be really useful. Humidification within the room and avoiding drying air conditioning. If you're staring at a screen like I am now, remember to blink because that will help the tears go over your eyes, and avoid smoky environments and smoking. There are many specialised eye drops, and again, these should be prescribed by an ophthalmologist, in my opinion. Cyclosporin is an immune suppressing drug, but it increases tears. Anti-inflammatory when your eyes are so irritated, and sometimes steroid eye drops for short times. You can't use them too long because they can cause cataracts or glaucoma, and that has to be under a specialist optometrist or ophthalmologist. There are autologous serum eye drops, so they take your blood, send it to the blood bank, they take your serum and mix that up with lubricants to put back into your eye, and they can be really soothing. Punctal plugs are little silicone or other types, collagen plugs they put into these little ducts, nasolacrimal ducts, to stop the tears or the artificial tears from draining into your nose so quickly. They can be really effective. And in the old days, and sometimes still now, the ophthalmologist can cauterize this area, so permanently block it. So you need to use far less artificial tears. Estrogen vaginal pessaries can be really helpful for dryness and pain. Skin moisturizers, nose lining moisturizers, chapstick for your lips, because often they're very irritated and peely, and treating any thrush from Candida that can occur in the corners of the mouth and inside the mouth without the typical white plaques we see in babies. It can just be red and sore. So treating that if you've got a sore mouth and you're not sure why. So the systemic symptoms and systemic drugs apply to both Sjögren's and lupus as well. There's a lot of overlap, as I said, and the treatments really overlap as well. For controlling symptoms, I think you're all aware of and can manage paracetamol, anti-inflammatories if you tolerate them and if they're useful, usually not all the time, but on and off. Some people need low-dose steroids, but we try to avoid them if we can because they do have long-term side effects. Injections of steroids can be very useful and give, even a month's worth of relief without the side effect profile being so permanent. Hydroxychloroquine in Sjögren's can be useful for skin and joint manifestations, but it hasn't been proven to slow Sjögren's down, but many people are on it and it probably does more good than harm. There are many self-management strategies before I go to the drugs that we prescribe. Just getting information, which you're doing tonight, inform yourself about the disorder and what's available. A healthy diet, don't smoke, sun protection, particularly for people with lupus because it can flare lupus, but also for people on Plaquenil, hydroxychloroquine, because that can pigment your skin if you see a lot of sun. Keep physically and socially active for your physical and psychological benefit. Make sure you get optimal sleep, pace yourself, explore pain management techniques, seek support, including from Hospital Research Foundation, Arthritis section, but many other forms and internet. Make sure you're using a good site because there's a lot of misleading things as well on the internet. And don't forget, which you'll need to do with your GP predominantly, to address all of your other medical and psychological health because your rheumatologist won't have time to go through that each visit. So depression, anxiety, blood pressure, cholesterol, cancer screening, osteoporosis, vaccinations, all are really important for all of us, so don't neglect that. Going into the drugs that we tend to use for Sjögren's and lupus when it's affecting organs, I'll just say hydroxychloroquine, which is Plaquenil, really should be used for everyone with lupus because it's very well shown that it will reduce flares and reduce severe complications. Not completely prevent them, but reduce them. So everyone with lupus should be on hydroxychloroquine unless there's a good reason that they can't, such as an allergy. Steroids, again, steroids are really important because they're quick onset for people with very severe inflammation where they might lose their kidney or might lose their lung function. So very important for severe disease, but they shouldn't be used for pain, okay? And I'm always talking about that. They do help pain, but there are other safer things to use chronically for pain. So disease-modifying agents, we have pinched some of them from our rheumatoid arthritis patients like methotrexate and leflunomide, particularly good for joint problems, inflammatory arthritis. Then mycophenolate, we pinched from transplant medicine, and we use a lot of that for lupus. It can be very good for all areas of the body in lupus, but is a stronger immune suppressant, so has to be monitored carefully. Azathioprine, similarly stolen from the transplant doctors, safe through pregnancy, whereas mycophenolate's not. So that comes into the decision-making. Tacrolimus, we don't use so much in Australia. A lot of it's used in Asia, but it can be fantastic for lupus as well. Then we've got the biologic era. So these are genetically modified or made proteins based on a lot of research that show chemicals that drive these disorders, and they're very specific. They just block one chemical at a time. So they're very expensive, but they can be very effective. We use a lot of rituximab because it's relatively cheap and easy to get in Australia. It's not been proven for Sjögren's and lupus in all trials, but in some trials there's a suggestion, but we know out of the trial situation it can be life-saving. Belimumab and anifrolumab have been developed through research, through clinical trials. They've been approved in Australia and around the world, but not yet funded in Australia. So we rarely use them because they're very, very costly. But hopefully in the next few years, we will have much easier access at a cheaper rate for those treatments. Clinical trials. It's, just mind-blowing and fantastic that we now have many, many clinical trials in lupus and Sjögren's. When I started clinical trials 30 years ago in rheumatoid arthritis, I used to nag all of the companies, why don't we look at Sjögren's? Why don't we look at lupus? They weren't interested. But now that we've got really good research output from around the world, they have been able to develop drugs that target these diseases. And they're now in phase 3 trials. That's the trial around the world with many people that if they pass, they can get them approved in different countries. So we're at that stage, which is really great. Many have failed though. Many have failed in lupus, and several, probably at least 4 that I've been involved with, have failed. By fail, we mean that it hasn't shown to be any better than placebo over the period of the trial. And we worry about this because we think some of them do work, but the outcomes that we're measuring over the course of a trial aren't sensitive enough to be changed within that period. So there's a big global effort, some of it being led from Australia, to improve those outcome measures so that we can get more drugs that work over the line. So the targets for the drugs that are currently in phase 3 clinical trials for Sjögren's and lupus mainly are targeting the immune system and the parts of the immune system that are overactive. So B cells, Janus kinases, so these are signals between the immune systems that switch on B cells, tyrosine kinases as well. So Janus kinases, we don't have to go into all of the names, but they're already on the market and readily available for rheumatoid arthritis and other types of arthritis. And they're just in phase 2 really for lupus and Sjögren's. So if they work, it's going to be great because many rheumatologists and other specialists around Australia are very experienced in using that. Deucravacitinib is in trial for psoriasis, psoriatic arthritis, lupus and Sjögren's. We've got a trial at the QE going for Sjögren's. And it's very exciting because it's a tablet and it's just been shown in a phase 2 lupus study to improve pain and fatigue, which is really rare for a trial to show. So we're hoping that's going to come forward in our Sjögren's patients as well. So CAR T cell therapy is a new kid on the block. I'll show you on another slide some titles of recent papers. So really, we first heard about CAR T in autoimmune diseases 3 years ago. They've been used. These are T cells, so the boss cells in the immune system that have been genetically modified to attack other cells in the immune system. They were developed for cancers, so they've been used in cancer therapy. And what they're doing in autoimmune disease is attacking the B cells. So just like I said, some of our other drugs are targeting B cells. These are revved up T cells that go around in your system and knock off the B cells. So there are some risks of CAR T cell therapy. You need to have chemotherapy first to ablate your immune system before they then give you those cells through your veins. So it's not all positive as far as safety goes, but the papers have shown in about 15 patients, these were done in Germany, about 8 people with lupus, 4 with scleroderma, 3 with autoimmune myositis were treated with CAR T cells. These patients had very severe diseases that had failed all of the treatments, including biologics. And 1 or 2 years down the track now, the patients are all in remission without any treatment. So this is like magic. It's got to be too good to be true, but we're all very excited about it. And many companies are now contacting we rheumatologists and immunologists that take part in clinical trials to see if we're interested so that they can bring these trials to Australia. So we're going to look carefully. There's many drug companies wanting to get in on this space. So we're going to band together, particularly the Monash Group and ours, to just perhaps back the ones that look like they're going to have the best treatment. T regulatory cells are another type of cell I haven't shown you. They're important in our immune system to dampen down autoimmunity. And actually, research has shown in Sjögren's and lupus, we don't have enough T regulatory cells. So there's now a lot of interest and trials starting up to increase the number of Treg, we call them Tregs, to help treat Sjögren's and lupus. So most of these are autologous, so they're made by boosting your natural Treg cells out of your blood, boost them up and pop them back in. Some trials haven't started yet, but they're going to use other people's Tregs and transplant them into you. So they haven't started yet. But more excitingly, there's a team in Australia that have developed specific T regulatory cells, so against the Rho antibody and other antibodies in lupus that have just been published, and to show improvement of lupus nephritis in mice. Not so far in humans, but the next step is to test them in humans. So that's here on the bottom left. This was published in January this year, and I'm collaborating with this very important group under Dr. Joshua Oy, Eric Morand, Alberta Hoy, and I'm leading the charge of Sjögren's to be included in this really fantastic research. Okay, so we're near the end. So just to mention the South Australian Sjögren's Disease Registry and Biobank. This is based at the Queen Liz and at the Basil Hetzel Institute. It was established in 1991, and we've got longitudinal information and blood samples from about 300 patients. That's caused us to be able to publish at least 75 publications in international high-impact journals, which builds the understanding of the cause and the manifestations of Sjögren's. We've discovered some genetic risk factors, new antibodies, and new manifestations. We collaborate with the European Sjögren's Big Data Consortium, where we have more than 16,000 people involved. And that's discovered more risk factors, including risks for mortality and the effects of climate change and pollution on symptoms. We've also got a collaboration with the genetics network around the world, which is based in Oklahoma, and we've found 20 new genes, well, the 20 genes actually, that predispose people to Sjögren's, and we're now looking at that in the immune and salivary cells. So we're finding targets for drug development. And so this, as Ben mentioned, we're poised for this South Australian Biobank and Registry to become national. So in the international group, just a couple of slides. This just shows women in orange, men in blue, and at the time of diagnosis of Sjögren's, what other areas apart from their eyes and mouth are affected. And you'll see about 50% of people have some sort of joint problem. About a third have joint problems, about half have overactive immune systems in the bloodstream, and then a lesser number of people might have blood cell reductions, enlarged glands, and then lung, skin, lymph node, nervous system, kidney or muscular problems in a lesser number of people at diagnosis. At the same time, we looked at moderate to severe Sjögren's around the world, and we found that in the darker colour, you can see 80% of people had at least moderate Sjögren's at the time of diagnosis, worst in China and Australia. I must admit, Australia is actually just South Australia because we haven't measured it in the rest of Australia yet. So we need to look further into this. You can't just rely on research that's done in another country. Countries are all different. The environment's different, genetics are different. So we're going forward with this. We have had a focus group 5 years ago of an Australian group of about a dozen Sjögren sufferers. And a lot of this will probably seem to be of relevance to you. And I think we can talk about this in questions and answers, but for many people, there's a long, frustrating and anxiety-provoking journey before you get a proper diagnosis of Sjögren's, but I'm sure the same for lupus. Dry eyes aren't just the only problem of Sjögren's, and the current treatment options are not right for everybody. And in South Australia, Sjögren's does impact many people, and it impacts living day to day, hobbies, activities of daily living, and many people, at least half, have to cut back on what they're doing every day, housework or work, modify the living space, and so forth. And the financial burden for Sjögren's in South Australia is high, particularly dental. That left side there, the blue line shows an average in the 12-month period, $1,300 out-of-pocket dental expenses, compared with $396 for average Australians. So it's a costly problem as well. Just to mention, there is a national lupus registry and biobank run by Associate Professor Alberta Hoy at Monash, and we've joined up with her. That was established 9 years ago, and there are 700 patients and growing, and there's many sites around Australia, which hopefully there'll be a map like this for Sjögren's soon. So we've got some research we're doing together. We want to combine and compare what's going on in Sjögren's and lupus for patient impact, molecules that are driving disease, and other risk factors. And we've got a sub-project studying these in Indigenous Australians. So this is how to get involved. I think we might leave it at that. I think that's my last. Yeah, wasn't going to go into that. So this is my last one. I'll just leave out. We'd love you to be involved in any of the research, and really need your voice to inform what we do. Thank you.
Thank you so much for that, Maureen. That was incredibly insightful and a fantastic presentation. We're really lucky to have you and your expertise, not just in Australia, but worldwide, present to this group tonight. So thank you so much to that. We'll move on to some questions if you're ready for those.
Yep.
So the first one, and these are questions that we had pre-submitted, and we'll hopefully try to get to as many as we can. The first question that we had came through is that, is there a link between recurring UTIs and Sjögren's?
They're not so much UTIs, but there is an increase in we call them lower urinary tract symptoms or LUTs, and they've got the same symptoms as a urinary tract infection. So frequency, burning on urination, getting up at night to go, urgency. And so, we had published a paper many years ago about that. And we think it's to do with some of the autoantibodies in Sjögren's that muck up the autonomic nervous system, make the bladder irritable. So yeah, there is more research going on. And there's a big interest in the American research into Sjögren's, into this area too.
Perfect. Thank you for answering that one. The next one we had is, how does having positive SSARO antibodies affect Sjögren's?
Yeah, so it's a diagnostic marker for Sjögren's, but only 80% of people have it. So 20% of Sjögren's sufferers don't have it. It's also a marker of lupus. In Sjögren's, it's related to a few things. So it's related to more organ manifestations, though not necessarily more severe, but yes, linked to the overactive B cells. It is related to the babies getting neonatal lupus, so that's the baddie that can cross the placenta. In lupus, Alberta Hoy has done a study showing that lupus patients who have Rho, I'm not sure of the percentage who have Rho, but they do have a higher immune system activity. They more often have the Sjögren's as well. And they do probably have more severe lupus. So yeah, Rho, we used to think Rho was just a diagnostic marker and didn't do anything, antibodies to Rho, but now we know that it is important in driving some areas of the immune system.
Perfect. Really well answered, Maureen. Thank you for that. The next question came through is asking more about, and we've had a few questions about diet that we'll get to as well. They're asking if there's anything that can be done in a dietary sense that will really help with the severity of dry eyes and reduce the need for eye drops every hour or so or during nighttime sleep.
Yeah, so diet's always of interest. And, you know, we used to, 30 years ago, diet, schmiet, you know, nothing going on, but diet's really important. We don't have a specific diet for Sjögren's. There's no controlled studies. There were some studies for eyes that weren't very well controlled, so we're not 100% sure about it. They thought omega-3 in diets might be helpful, and so some of them even give omega-3 like fish oil supplements, and that's fine. There's a lot of really good scientific research into autoimmunity in general, and even inflammation in general, including asthma, showing that the best diet, which is the other word for it is a anti-inflammatory, because it affects the microbiome, the bugs in your gut that chew up your food and can put these anti-inflammatory molecules into your system, is Mediterranean diet. So it's high fiber, you know, a lot of vegetables, legumes, low sugar, low, highly produced food. So it's just what your mother told you. That's all we know.
Wonderful, really well answered. And I'll jump on that too, is that we've done 2 previous fantastic webinars with a expert nutritionist, Dr. Evangeline Mancioris, who really covered both of those, and especially in that Mediterranean diet in really good detail. So what you can do if you want to look at that, you can go onto our website or you can go on our YouTube channel as well. So someone's asking, you kind of touched about this with the diagnostic and the blood tests. Do people with either of these conditions, do they always have positive blood results for the antibodies?
So in lupus, 99.99% would have an anti-nuclear antibody, ANA. There are rare cases of ANA negative lupus, so that really needs to be sorted out by a specialist. In Sjögren's, no, only 80% have ANA and only 80% have anti-Rho. So that's where it becomes tricky. An ultrasound can be useful of the salivary glands. If they're perfectly normal and the Rho is negative, there's a low likelihood of having Sjögren's. But a lip biopsy, a minor salivary gland biopsy, often needs to be done to be sure.
A couple of questions that we had were about that CAR T cell therapy, but I think you covered that fantastically. So you mentioned a little bit about rheumatoid arthritis, and someone's asking if the treatment for Sjögren's differs from that for rheumatoid arthritis.
Yep, I'll just backtrack to CAR T because although there's a lot of excitement about it, we won't be able to use it in Australia until it's, or anywhere really in the clinic, until it's proven in clinical trials to be effective and safe. So these publications are on one cohort in one department. So yeah, we won't even be allowed to do it until there are clinical trials. But of course, patients will be able to go on to clinical trials. So the phase we're at the moment is we're selecting what companies we want to work with, and they're selecting if they want to do work in Australia or not. Yes, so we do borrow a lot of treatments for rheumatoid to treat Sjögren's and lupus, particularly the joints. For people with rheumatoid arthritis, so methotrexate, leflunomide in particular. And Many others tend to avoid sulfasalazine because we do know sulfa drugs can flare these up, these diseases. But some people get away with it and it can help their joints. TNF inhibitors can make lupus and Sjögren's worse. There's sort of a seesaw within the literature of TNF is a chemical that can drive rheumatoid arthritis. There's another chemical called interferon, type 1 interferon, that drives Sjögren's and lupus. And there's a bit of a seesaw. If you block one, the other one can get overactive. So that's why if you block TNF, the interferon might get overactive and make Sjögren's and lupus worse. So yeah, some things are probably going to be useful for both. Some are going to be only for rheumatoid or only for the Sjögren's and lupus.
Perfect, really well answered, and I think it shows the level of expertise and the things that there's so much that rheumatologists take into consideration for what treatment they give patients, and how lucky we are that we've come so far with these medicines.
Mm.
Someone's asking, and you covered it a little bit as well, for the treatment options for dry eye. And they said that they've tried lots of different over-the-counter artificial tears that aren't really giving any relief. Is there anything outside of those artificial tears that could help?
Yep, so always check if the patients are using preservative-free eye drops. So drops that come in the bottles, except for the newer ones, Hylo Fresh and Hylo Fort, they do have a filter and no preservative, so you can use them freely. But the other ones tend to have a preservative in them so that they last for a month. But that preservative, when you need frequent eye drops, can irritate the cornea and make things a lot worse. So first check that you're using preservative-free eye drops. Secondly, it's often useful to try some of the gels, liquid gels, or even the ointment gels, particularly at night going to bed. So the ointments can make your vision blurry. So if you're not having to get up and down all night, it's fine then. But the liquid gels often don't make it too blurry and can be really soothing. So try them, try different types because they're all different. But then, yes, if you tried a number of different types of eye drops, gels, ointment, then do see an ophthalmologist for these other ones, cyclosporin drops, autologous serum drops, and punctal occlusion. They can all help.
If I can ask a question with that seeing an ophthalmologist, what would be the best referral pathway if someone feels like that's what they need to go down, they haven't seen one yet? Would that be through their rheumatologist or through their general practitioner?
General practitioner usually, yes. Yeah. If it's urgent and I want someone to be seen more quickly, I'll, obviously with contact with the GP, I'll send the referral for them. But no, I'm most happy if the GP could do that. The referral lasts longer. From a specialist, it only lasts for 3 months. And I'm happy, and I think all rheumatologists would be happy if the GP attaches our report to the GP with their referral to the ophthalmologist, so they've got that background information.
Perfect, really well answered. Someone's asking, and this might be a bit of a personal one, so it might be hard to give direct advice about. They're saying that they've been diagnosed with Sjögren's disease, but then their GP saying that they might have lupus as well. Now they're saying that they've seen a rheumatologist and they've said that they don't have it because there's not that red butterfly. Can you give your thoughts about that, or is that a bit too much of a personal one?
It is. I can be sort of general because it is common, because it is tricky to diagnose it. Even for rheumatologists, it can be tricky because we're really attributing symptoms, and many symptoms are not specific, like fatigue, for example, can occur in other disorders. So tricky to see which is the dominant thing. For example, if there's a kidney biopsy showing lupus, they've definitely got lupus. If there's a biopsy showing Sjögren's from the glands, it's definitely Sjögren's. But there are overlapping features that could be either. So kidney inflammation, lung inflammation, skin inflammation. There's a skin inflammation called subacute cutaneous lupus, and that can be seen in lupus or Sjögren's. So you can see why GPs can be mixed up about it as well. So it comes down to categorization, and that changes over time. You know, I showed you one list for lupus classification, but that's different than the last two that we've had in the last 10 years. So at the moment, my own personal preference is if they fulfill criteria for both, I'd say you've got both or an overlap. But you don't have to have the malar rash for lupus. If you've got it, it's very, you know, pretty well going to be lupus. But many people with lupus don't have the malar rash. So it's difficult. And in the future, I think we'll have better definition. We're looking for funding around the world, but in Australia as well, to do multi-omics projects. So we're not going to just map genes, but we're all of the proteins that are in the bloodstream and in the glands of people with Sjögren's and lupus, and then compare them. And we'll find that there'll be a group that'll be like a Venn diagram. The group in the middle look exactly the same biologically, and we're calling them one or the other. There'll probably be a third group. You know, we'll call it something different. In the old days, you know, 200 years ago, all arthritis was called rheumatoid arthritis, or actually it was called gout first, and then rheumatoid arthritis. And then we've got all, you know, 200 types of arthritis that have been figured out now. Sorry, that's probably more confusing than clarifying.
No, I think that's a fantastic answer. Someone's questioning that if Sjögren's disease can lead to lung disease. Can that happen?
It can. So you might remember that triangular sort of graph I showed for our worldwide survey. I think about 10% of people at the time of diagnosis, might have been 8%, did have some lung problems associated with Sjögren's. And overall, we think about 20 to 30% of people with Sjögren's will develop some sort of lung problem. Mostly it's mild, and it can just be a bronchitis or a smaller airway bronchiolitis. So it can be a little bit like asthma. The other extreme is some people can get very severe interstitial lung disease and pulmonary fibrosis, and that needs immune suppressant treatment and antifibrotic treatment to normalise it, to stop it from getting worse. So the guideline now for Sjögren's, but actually for all connective tissue autoimmune diseases and rheumatoid, is at baseline. So when you first see your rheumatologist, we ought to be getting lung function tests and considering imaging, like a scan of your lungs as well. So we know what you're like at the start, so that if you develop symptoms or signs down the track, we can compare it and see if it's got worse, and if things are worsening, we need to get in with treatment. So yes, we're very focused on watching the lungs.
Perfect. Really well answered, Maureen. Someone's asking about myositis and Sjögren's, and they're asking if exercise, and they said rather than meds, but it's possibly a combination, can slow down the progression, or is that worthwhile?
Yeah, I think you've hit the nail on the head, Ben. Combination is the way to go. So myositis can occur in Sjögren's in up to 10% of people. Thankfully, it's often readily treated with drug-wise with methotrexate rather than having to go on major intravenous treatments. But I always say, there'll probably be people online saying I don't always say it, but I try to always say that the role of physical exercise is just as important as the treatment that we're giving to suppress the immune inflammation in the muscles. So they work together. You know, if you don't treat myositis, your muscle cells will, some of them will die and be replaced with fat, so you don't have a strong muscle. So it's really important to reduce that inflammation with drugs, but you've got to grow your muscles back and strengthen the remaining muscle fibers. And the only way we can do that is by exercise. So they work really well together.
Perfect. Really good explanation with that one. Someone's asking that they've read a little bit about Enterococcus glanarium and its possible roles at triggering Sjögren's and lupus, and if you have any more information on that one.
I really admire this set of patients with Sjögren's and lupus, because you're often on top of the literature. And I've had, right from the start of CAR T cells, people have been emailing about it. And I must say, I haven't heard of this bug before. So thank you for bringing it up. I did look it up. And yes, there's some research showing that it's a common bug that we all probably all have. We all have immunity to the bug, but in a subset of people with lupus, it seems to be associated with a set of autoantibodies in lupus. So it may even be driving the disease onset. It might, don't know how, but it might be by molecular mimicry, which is what we've assigned to many viruses and bacteria over the years, that part of it might represent code of protein, which is similar to a protein in the body. And so the immune system attacks the bug and thinks the body's the same thing. So that's molecular mimicry causing autoimmunity. So yes, it probably is one of many germs, bacteria, as well as viruses that can trigger lupus and trigger probably Sjögren's as well. And there was an interesting paper in the recent years, and we're trying to reproduce it in Australia, where they looked at people diagnosed with Sjögren's for the first time, and they looked back at hospital admissions over the 5 years preceding the diagnosis. And there were more hospital admissions for different sorts of infections like pneumonia, cellulitis, before Sjögren's was recognised. So that's interesting. There's probably many things that are triggering it.
I think it's one of the big takeaways that I've certainly come from today, is that there's so much research and so much going on to actually trying to find out those different triggers and things like that. So it's a fantastic work that people are doing. We've just got a few more, and then we'll let you go. It's been fantastic with your time. Someone's asking if a lacrimal gland enlargement on a CT is a common finding, and that it's causing a ptosis.
It's not a common finding, but it occurs in Sjögren's. So the lacrimal gland is in this area just under your eyebrow, and that's where the tears are made and pumped in by a duct to your eyeball. And that is part of Sjögren's. It is, if you do biopsies, it is full of those inflammatory T and B cells, just like from the minor salivary gland biopsy, but we don't routinely do it, of course, because it's not a good place to biopsy and leave a scar on your eyelid. But most people with Sjögren's don't have big glands either, salivary glands, but some do. And so some do have a big lacrimal gland. But there are many mimics. So there's another disorder which was called Sjögren's for a long time, with big salivary glands and big lacrimal glands, called Mikulicz disease. And we now know there's probably another disorder that causes most people who have Mikulicz disease, and that's called IgG4 related disease. It's rare. But there can also, particularly if it's on one side, be other things infiltrating the eye gland, the lacrimal gland. So often it will need biopsy to see what's going on. And, there's a really good team of ophthalmologists in Adelaide, at least one team, that do this regularly to make sure nothing else is going on.
Perfect. Really well answered, Maureen. And the final question, we'll see if you're comfortable asking it or not. Someone's asking if there's a long wait for an appointment to see a rheumatologist at the Queen Elizabeth Hospital.
I think across the board, there is a much longer wait than we would like across South Australia, actually. I think compared to some of the other states, we have much lower number of rheumatologists versus population. So I think in my experience, public and private rheumatologist wait lists in South Australia are pretty long, longer than we'd like. So all of the private and public groups do triage the referrals, so that the ones that do look urgent, that they might cause immediate danger to patients, are seen first urgently, and the ones that do need treatment pretty quickly, like rheumatoid arthritis or lupus, are seen, within 2 months and so forth. So sometimes they push out. sadly, you know, there's people that have disorders that we really want to see and help with, but aren't urgent. They're not going to cause joint damage within months. Then they tend to go on the triage 2 or 3 to have to wait a bit longer. So we really want to protect people from getting any damage before we see them. And there's constant lobbying for the government to fund more training places so that we can have more rheumatologists in South Australia.
Maureen, thank you so much for your time. It's been an incredibly informative session, and I'm sure all the attendees agree with that. I'll say that we record all these sessions, and then for everyone who's come along or everyone who's signed up, we'll email it out to you. Again, I thank you all for coming along, and Maureen, thank you so much for taking some time out of your night to spend it with us.
It's been a great pleasure, and thank you everyone for tuning in.